Mobilization. Why do we mobilize? Mobilization has strong evidence that it can reduce pain or increase range of movement. And the issue is we have to be quite specific why we're doing this mobilization technique and what objective would we like to achieve, what therapeutic aim we would like to achieve by mobilizing the patient. In this video, briefly I will use the spine model to explain different type of mobilizations that we use and what could be the effects, and I will use it as an introduction to the practical demo that will be in a model in a few minutes. First of all, we have cervical spine vertebrae, and we have a facet joint, or what we call zygohypophyseal joint, but also we have the joint of Loschka, or the oncovertebral joint, which is mainly between C3 and C6. Patient has limitation when turning his head to the right or left. From our assessment, it was clear that he has limitation related to arthrogenic structures. This could be an indication to mobilize either the zygohypophyseal joint on one side, or sometimes if he has limitation on the sagittal plane, we can mobilize on the sagittal plane by applying the force on the spinous process. Just for terminology, we call this posterior-anterior passive accessory gliding. If we are applying the force over the spinous process, if we are applying our force on the transverse process to move the facet joint or zygohypophyseal joint, we call it posterior-anterior unilateral gliding. Both of them, we call it passive accessory intervertebral mobilization. Why? Because we are moving the joint passively, either by targeting the spinous process to move both vertebrae against each other, or by targeting the transverse process to move the two articular surfaces of the zygohypophyseal joint against each other in order to achieve pain relief or increase the range of movement. Patient has sort of compression or irritation of the nerve root. Again, unilateral posterior-anterior gliding could help decreasing the pressure or the irritation on the nerve root. Okay. Patient has high irritability. Every movement within the neck is painful. We can use low-grade mobilization, either central or unilateral, very low grade, in order to inhibit the nociceptors and increase the amount of endorphins and give the patient some assurance. So to repeat, just to summarize, we have unilateral central PA, we have central PA, we have unilateral posterior-anterior gliding, but also we have other type of mobilizations that we call passive physiological mobilization. Passive physiological intervertebral mobilization, where we hold the patient head and move it to different direction passively. This could be rotation, this could be side flexion, this could be retraction by only moving the upper cervical spine, or it could be extension by moving the whole head backward. Again, these all are passive mobilization where we just moving the patient head toward different direction passively in order to decrease the pain or increase the range of movement.